Good afternoon, or good evening, I might say. It's 6 o'clock on the East Coast, which means 4 o'clock here in the Rocky Mountains. And it is time, as it is every Tuesday evening at this time, for Fertility with Fink and Friends. My name is Dr. Randy Fink, and I am the Clinical Director of IVF Services here at CNY Fertility in Colorado Springs. It is great to see everyone here, as always, on a Tuesday. We've got a bunch of different feeds here going on. We've got my Instagram feed, we've got CNY's Instagram feed, we've got Facebook and YouTube and LinkedIn right here in the middle. And I hope it's been you had a wonderful weekend, and it was a great week so far. A great happy Tuesday. It was a pretty happy Tuesday over here. We're pretty busy in the operating room and in our clinic here today at CNY. In Colorado, we had a little snow, and then it got warm here again. And gosh, it's just that crazy kind of Colorado winter. But those folks a little further out west from us are certainly suffering with an unbelievable, really an incredible amount of snow. And so again, they have been having such a trial with all the weather between the rains and now the big blizzard over there. But thoughts going out to everyone who needs us this week, because lots of folks are in need. Lots of folks are having a tough time of things, and it's not just those things in life that are causing difficulties, like things with the weather and then the snowstorms, or maybe things with the car getting it to run, or things with the family, things at home. There's things with fertility, and we know that every step of the journey, every step of the adventure is one that may be riddled with stress, but we persevere. We live each day. We look forward to tomorrow with the hope that tomorrow brings something better. And most importantly, that we stand together as a community. This is one of the most giving communities I have encountered. That is to say, with people who are willing to share their own experience and their own personal expertise with what they've been through. So thanks to everyone. And, as I always say, let's lead forward with kindness, lead forward with love, and most of all, lead with hope. Hope for tomorrow. Share a little kindness with someone who needs it, because there's just not enough of it in the world right now. So that said, let's see who we've got joining us today over here on the CNY side. We've got it's La Jessica was the first to join. A very special hello and thanks for being here. Self-explanatory. David J. Daniels, Megan, hi to Lily Rios. Good afternoon. Shabnam TKS, hello to you and welcome. Das Crazy Dog Lady, good to see you here on a Tuesday as always. Ski and Sand 802. I like the way you think. Let's see what else we got here. Over on my Instagram side, Joni Rose was the first to join. So thank you for being here on this Tuesday afternoon. As always, special shout outs go to two very special nurse practitioners I would like to say hi to. One is my dear friend and colleague here at CNY in Colorado, and that is Brandis Montez, who is watching. Brandis is an extraordinary clinician, and I'm very proud to have her as part of our team here at CNY. And also a special shout out to Alexis Lorente in Miami, Florida, at the Miami Center of Excellence, a wonderful women's health nurse practitioner. And that's also a very wonderful place to monitor for your IVF if you are going through the process. We've got the equestrienne. We've got Kara Smith, Katie Flores, Sabrina Dorothea, and a special shout also to Zenny in Miami. It's a good day to be in Miami, I suppose. Melissa Salustio, Nurtured Shannon, nice to see you and your wonderful words of wisdom. Hello to Leah, White Swan, Joni Rose over here, Faith, Hope, and Love. Yes, indeed. Courtney Ann, good day to you. Thompson, Kayla Thompson, M. Kid. Jody Allison, hello. Let's see what we got here. Also, one more special hello to my wonderful parents who are watching from South Florida. Bama Gal has joined us with that. They love to watch. We love to watch that Fertilizer with Fink and Friends. I am Fink, you are Friends, and so it is a good place to be on a Tuesday afternoon. So Nurtured Shanna here says, oh, actually, let me just say also hi to our Facebook and YouTube and LinkedIn folks. We've got Neri and Jessica, Melissa, and Adrian, yeah, and Molly. Well, so let's see what we got here. I started to say, Nurtured Shanna says, is 75 days of Omnitrope significantly more effective than 45 days of it? So Omnitrope, we know, is human growth hormone. It's one particular brand of human growth hormone. And as I understand, there have been some difficulties in the manufacturing side of things for folks being able to get a hold of their Omnitrope, of their growth hormone. Growth hormone is what keeps us young. Growth hormone potentially has the ability to help stabilize some of the age-damaged DNA at the level of the ovary. So we use it for egg quality. Now, the fact of the matter is that the studies are frankly controversial. They're equivalent on growth hormone and whether it really truly makes a difference for people. Here at CNY, we use it very commonly, very regularly, and in my personal experience, I've seen it make an awful lot of difference for folks with their egg quality. But I will tell you that there are some clinics that don't use it at all. And the evidence, the data says there are some studies that show that it helps, and there are other studies that show that it really only adds cost and doesn't really do a whole lot for cycles. I personally am a believer. So is 75 days more effective than 45 days? I think that's hard to answer, Shanna, because there's just no good evidence to tell us specifically one way or the other because of some of that controversy in how it works and how well it works and how to, most optimally use it. In my opinion, I think 3 months of growth hormone is great. I think 21 days is probably the minimum I would use. There are some clinics that will only use growth hormone just during a stimulation, so 9 to 12 days of growth hormone. But in my opinion, up to 90 days. Is there a difference between 30 days and 60 days and 90 days? Again, I would be guessing, but I do think that there is some additive effect over time. So yes, I think 75 days is probably better than 45. But at some point, you certainly reach your, you reach your fill with it, and then there's not much more, that it's going to do. I think you max out on the effect eventually at some point, but when that is, we don't know. Do you have to wait a year after birth to do a retrieval? I would say no, absolutely not. This comes from Kayla Thompson. I do think we're not excited about doing an embryo transfer shortly after you've delivered because your body needs to recover from that. And as you may have heard me talk about before, a short interconceptual interval is really the most preventable, really the only preventable risk factor for severe preterm birth. So we don't want you, turn up the light here a little bit. We don't want you doing an embryo transfer, but a retrieval, really in theory, you can probably do, about any time. If you're breastfeeding, we don't want you on the hormones, and they will have some negative effect on, they kind of all don't work together. No, you don't have to wait a year to do an egg retrieval. In fact, the earlier you can get your eggs, the better off you're going to be, because the more stable the DNA is, the younger you are when those eggs are retrieved. So waiting an extra year to get eggs, not necessary at all. Happy Tuesday to Melissa. The recurrent pregnancy loss panel came back with a slightly elevated white blood cell count. Well, I wouldn't think that that's That's has too much to do with recurrent pregnancy loss, as well as the MTHFR mutation, a heterozygote. So, what does that mean? MTHFR stands for, you ready for this? It stands for methylene tetrahydrofolate reductase. I just like saying it because it makes me sound so scholarly. And let's be clear, that is what's most important, that I sound scholarly. But methylene tetrahydrofolate reductase, MTHFR, that signifies that there may be some difficulty, Melissa, in the way that you metabolize your folic acid or your folate. The truth is, well, folate is ultimately metabolized in the pathway with a chemical in the body that's known as homocysteine. And if your homocysteine levels are ultimately elevated, that can cause an increase in your clotting risk. However, and here's the most important thing, I wish that we didn't test this MTHFR thing in these recurrent pregnancy loss panels, because the evidence shows that it really doesn't have anything to do with recurrent pregnancy loss. So back in the day, we used to think that, oh, an MTHFR mutation meant that you were likely to have an increase in the body's tendency to clot, to form little clots in the small blood vessels. Now we know that that is not the case. And so an MTHFR mutation really does not have any effect on recurrent pregnancy loss. So what does it mean? Well, so I find in general for folic acid, so then they said, all right, well, so if you've got this difficulty, this anomaly in the way you metabolize your folic acid, you want something called 7-methylfolate as a different type of folic acid. I think that that's actually probably a good alternative for really everybody, because most people don't have the test, and so they don't know. And frankly, it's not worth doing the test to see if you're a carrier, because it doesn't really have any clinical significance. Like I say, I wish it wasn't in the recurrent pregnancy loss panels anymore, because it doesn't really change our thinking on that. But it does mean that there's that special type of folate that I would recommend that you get in your prenatal vitamin for sure. Let's see what we got going on here on the CNY side. The crazy dog, das crazy dog lady. I am going to be back and to have another ultrasound tomorrow. What can I do to make sure that my bowels are not in the way? Well, so yep, sometimes, especially when you have smaller ovaries, the ovaries can be difficult to see because, you know, inside the pelvis, there is a lot more intestine than there is girl parts. And so when that intestine is full and you're full of gas and so forth, it can make it very difficult for you to see. Now, there are sometimes instances where we will tell people, maybe you want to use a laxative so that we can really get a good look. But in general, what happens is that once we've started to eat and consume food, we start to make more gas in the bowel, and the gas makes the bowel move all around and forms a lot more shadows. It makes things more difficult to see. So maybe one trick there, crazy dog lady, is don't eat or drink anything really before you go and get your ultrasound, and that may make it a little easier to see on the inside. Hey, that's a really good question, though. You know, I got to tell you, Froggy Decor, I like it. Hi, Gabrielle and Lindsay Jordan. How do I get permission to transfer to in the Colorado office? So we generally will tell you that we want you to go by the guidelines, the ASRM guidelines. And so we won't actually give you permission, quote unquote, to go against medical advice, because that is your choice. There's a consent form that we have you sign that kind of goes through all the risks that are associated with multiples. And if you are outside the guidelines, we will have you sign the document, but technically speaking, we're not going to give you permission to sort of break those rules. You can choose to break those rules yourself, and as long as we don't think that it is imminently dangerous for you, we will generally do it. We will not, for instance, transfer 3 euploid embryos. There are some folks who tell us, well, I want to have twins. I want to transfer 2 embryos. We will never tell you that that's a good idea, and we will never encourage you to do that, and we will never counsel you ways to try to make that happen because it's frankly it's unethical in most cases, and having multiples, sounds like a good idea. It's endearing to think of twins, and everybody knows some twins that they're all fine and everything's normal, but really the risks are very significant. And so, it's an individualized choice and decision, and we're happy to talk with you about it. But Lindsay, if that's what you want to do, generally, if it's 2 embryos, we will do it. You'll just sign a form. Ski and Sand 802 says, what's the referral process to your clinic? Excited to come get your support in the Albany location. So if you would like an appointment with CNY, you can request that online. It does take a little bit of time to get those appointments on the books. It may take 3 or 4 months to kind of get in. We are the lowest cost IVF in the country that I'm aware of. And so our list of folks who are waiting to have consults is long, but honestly, I think it is worth it. That appointment you can request online, or you can call us through the call center, and we are happy to schedule an appointment. You don't need a specific referral to come see us in most cases, certainly not through us. If there's some insurance issue that your insurance covers it and you need a referral in that regard, that may be a different story. I try not to tell anybody anything about insurance because I don't know about those things. However, really all you have to do, Ski and Sand, pick up the phone and call us, and we'll look forward to helping you out. Equestrian 33 says, how important is the genetic carrier screening? I thought I had it done, but that was a karyotype. I'm 3 weeks away from an egg retrieval and scrambling to try to get it done. Well, so the genetic carrier screen is a test that they've been able to identify the locations on our chromosomes for about 500 different genetic diseases. And it is not at all uncommon to find that you are a carrier of one or more of those diseases. Now, if you're a carrier of one of those diseases, it really doesn't mean anything unless your partner happens to be a carrier of the same thing. And if it turns out that you are both carriers of the same thing, it gives you a 1 in 4 chance of having an affected baby. And the time to find out about that is before you get pregnant, because especially if you're going to be doing IVF, we can prevent you from having an affected baby through the process known as PGTM. So if you can avoid having a baby affected with one of these dreadful diseases, then that's generally speaking, a good idea. Fortunately, most of these diseases are pretty rare. They are not so common. Some of them are more common than others. Things like cystic fibrosis, things like sickle cell, things like there are different types of muscular dystrophy. There, some of these things that you've definitely heard of, congenital adrenal hyperplasia. These are things that happen more commonly. But I will tell you that most of the things on that genetic carrier screening list are fairly rare. So the odds of both you and the partner being carriers is pretty low. But is it zero? No, it's not. So I really do think that it makes sense to have that carrier screen done, and it is considered a standard of care. So in our system, if you elect not to do it, you will sign a form that says that you've chosen not to do that testing. And then, you kind of run the risk. Well, what happens if I have a baby that's affected? Well, it could have been prevented. So that's why I think it's a good idea. Now, if you're 3 weeks out from starting your egg retrieval and you get that test done pretty soon, you will probably have it back. You will certainly have it back by the time you do your egg retrieval. Now, the problem is what happens if you do it and you come back positive with something? And again, that happens not infrequently because there are so many of these different, genetic mutations. Then we got to test your partner, and that may take another few weeks to get those results back. And by that time, you'll be into the point where you are, time for retrieval. So I would, really suggest try to get that squared away before you start, really, if you can. Neri says, recently had a laparoscopy done, during which the surgeon found a Meckel's diverticulum. So that is an issue that is in the bowel called a Meckel's diverticulum. The surgeon advised that I consult with a colorectal specialist before attempting to conceive to assess the size of the Meckel's diverticulum and determine whether removal is necessary prior to pregnancy. What's your opinion? Are there potential complications if I were to become pregnant before consulting with the colon doctor, particularly if the Meckel's diverticulum is deemed to be large in size? Well, I will tell you that is an unusual kind of finding. A Meckel's diverticulum is kind of a big outpouching of the bowel, and can cause issues in life. And you are more likely to have a bowel issue with that Meckel's diverticulum, whether you're pregnant or not, because simply of the fact that it's there. Now, if you get pregnant, I don't know that pregnancy itself increases the risk specifically, although as the uterus grows, it moves the bowels, the intestines kind of all around and things change. But I still don't recall that pregnancy itself increases the risk. But I can tell you that if you did run into a problem while you're pregnant, then you potentially put your pregnancy at risk because of it. So I would think it's probably a pretty good idea to just get that consultation and see what's what before you get pregnant. Once you get pregnant, things change. It is often difficult to find specialists who will agree to see you because many of them fear people who are pregnant. Many of them fear that pregnancy is a horrible communicable disease because it involves a parasite known as a lawyer. Because if anything happens to you during pregnancy, people fear that you're going to get a lawyer and somebody's going to be to blame. And so there are many specialists who will outright refuse to see you during pregnancy because of the pregnancy. So again, I think if you can get that addressed before you get pregnant, you're in a much, much better place. Jessica is here also and says, waiting to start my cycle around March the 17th for stems. And my first egg retrieval, when should I start the antihistamine protocol? So the antihistamine protocol is part of our immune protocol. And generally it starts in the beginning of your stimulation cycle. So sort of when you start your stem medications, that would be a good time for you to start the antihistamines. Let's see, Melissa Fees says, do you recommend anything to help with diminished ovarian reserve for a 33-year-old woman? The answer is yes. There is a whole protocol of supplements that we recommend for diminished ovarian reserve that come from a book that's called It Starts with the Egg. I have that list for you if you will message me through Instagram. That's at Randy Fink MD. I am happy to send you that list. I also have written an ebook which will likely be published. You know what? Let's talk about that. I've got a couple of things. Kind of exciting news, a little ebook that I'm going to have published that kind of goes through in a very straightforward and easy way what the supplements are and how you can establish a protocol for yourself that you should be using for egg quality. And also another little item, it's an audio book that I've written and been working on that's called Fertility Simplified: Stories of Hope and Success, where we talk about lots of different, fertility scenarios and how folks have gotten through them, what those struggles are, both medically speaking and emotionally. And I think it promises to be something that everyone will enjoy. So hopefully by next week, I will have a link for you, or I'll have that on my Instagram where you can avail yourself of that. Let's see, Adrienne says, thank you for taking the time out of your day to do these videos. Oh, my pleasure. I love learning new things. I have a consultation in May, but what are the chances for pregnancy with a woman that had a tubal ligation and wanting a baby with husband? Also, so confused about the process. Any place I can read up on the journey so that I am educated to know what happens when we start. Yes, indeed. So, a tubal ligation happens when we put a blockage on the fallopian tube to a person who believes they want permanent sterilization. And so that roadblock prevents sperm from being able to reach egg, and ultimately is considered to be permanent. Now you can try to reverse a tubal ligation; doesn't always work, and it's kind of an expensive surgery, and really honestly, with the cost of IVF at CNY, it's much less expensive probably for you to do a round of IVF with us, because when you do in vitro, we are revving up the ovaries to retrieve eggs. The eggs go to the lab where partner sperm meets the egg and creates the embryo. So they are bypassing that meeting that normally happens in the fallopian tubes. And then rather than that embryo floating its way down the fallopian tube, we place the embryo back inside the uterus, Adrienne, and that results hopefully in you getting pregnant. So pretty straightforward process. You know what? If you take, and it sounds so scary and it sounds so difficult and complex, but to be honest with you, we really have it down to a science. It is pretty straightforward. There is a book that you can get for free from our website, the CNY Fertility website, called the Family Building Guide, and that really walks you through the entire process, tells you about each step of the way, what all is involved, and so forth. And we are looking forward to helping you and your partner have a baby. Molly asked, do you have any experience with celiac disease affecting embryos not implanting? Celiac disease, which is a disease of the bowel. It's basically an allergy to gluten or sensitivity to gluten, which is a component of wheat. So it's really in everything. People with true celiac disease do have often have fertility issues. Yes, indeed. And so, one of the things that we tell folks is that if you can be on a gluten-free diet, your fertility improves. Molly, as you know, telling people to go gluten-free is not an easy thing to say. It's sort of like saying, oh, yeah, I can give up soda. Oh, sure, I can give up soda. Well, you know what? Then I see a Coke and oh gosh, and just the sound of it opening and pouring over the ice and hearing the bubbles and just feeling that taste. I'm like, oh man, I really want that Coke. You know what? Coke isn't necessary, and you could give up Coke, Coca-Cola, if soda, if you wanted to. Giving up gluten is a huge major life change because gluten is universal and it's just in so many places. Going out to a restaurant, everything changes when you go gluten free, but it does make a difference. It makes a difference in your life, and I can't tell you the number of people who have shared with me how much better they feel when they do in fact go gluten free. It does make a difference in fertility. Yes, it can have an effect on embryos implanting. So what do we do for that? Well, that's one of the things that we use the immune protocols for. And so certainly I think, Molly, that's worth having a good conversation with us about. Hi to Ash and Compiano and Bree Bales. Nice to see you here. Siciliana Melissa says, I am on Orlissa and letrozole for suspected silent endometriosis suppression before an embryo transfer. How do we know if it's working? I had an estradiol that was below 5 and an FSH that was 16 tested because I got a period my first month. Well, so you don't technically speaking know that it's working. So, if your estradiol is below 5, then that means you really don't have any estrogen that's there to be potentially feeding that endometriosis. And that's really what we're after. There is no evidence to say that we should be testing for it again once you're treating it. So if you're treating it for those 60 days before you do an embryo transfer, we know that it can bring the success rate of an embryo transfer from below 10% to greater than 60%. So the evidence shows us that it does work, but there's not really a specific test that's recommended to see what it's doing or how it's doing or whether it's making some difference or not, because testing in the blood may not have anything to do with what the medications are doing at the level of the endometriosis itself inside your pelvis. Hi to Kathy Hull. Courtney Ann says, do you recommend IM progesterone shots if my progesterone is high enough with suppository progesterone? If not, what's the optimum range for progesterone levels? Okay, so here's the situation. You are talking about progesterone in oil injections during a frozen embryo transfer cycle. If you are doing an FET, for that matter, even if you're doing a fresh transfer, the evidence on that is very clear that that the outcomes of those embryo transfers is dramatically higher if you are using progesterone in oil injection. And in an FET, that's assuming that you are doing a medicated cycle, because in a natural cycle, you're making your own progesterone and you don't need the progesterone in oil. So if it's a fresh transfer or a medicated cycle natural, or a medicated, if it's a fresh transfer or a medicated cycle FET, you absolutely need the progesterone in oil. Your success rate drops by almost 70% if you don't use progesterone in oil and you just try to use vaginal progesterone. Vaginal progesterone is said not to be sufficient for a medicated cycle or for a fresh embryo transfer. It is, however, an okay adjunct to use along with the progesterone because its effect is local. Now, you say that your progesterone level is high enough, which suggests to me that maybe you are doing a natural cycle FET. And if you're doing a natural cycle, then progesterone intramuscularly is not needed unless your level is too low. We still give you some vaginal progesterone because, again, it's a local effect where we're trying to just boost the progesterone at the level of the uterine lining itself. In a natural cycle where your body is making your own progesterone, we look for that progesterone level to be at 10 or above for an FET. And if it is a medicated cycle, we look for that number to be above a 20. So hopefully that is helpful, my friend. This comes from Jado Recki, I believe that says, would you recommend a second retrieval if a patient only retrieved one embryo? I would, because again, what I tell people, IVF is 100%, it's a numbers game. It's about getting enough eggs to make enough embryos so that you have enough options. How likely would one embryo get you pregnant? It could, but you're certainly going to have better odds if you can bank some embryos. And really the answer to that question depends on how old are you, and are they day 3 embryos or blastocysts? Are they tested embryos? Even for a tested or a normal euploid PGTA tested embryo, which is our highest chance of success with IVF, it gives you a 65% probability of pregnancy, which means, well, there's still, substantial chance it doesn't work. So we usually tell people we'd like you to have, even with a euploid embryo, 2 normal euploid embryos for every baby that you would like to have. So I would suggest, I think having more embryos is probably a much safer bet for your family. Hi to Nadia. My husband and I did our first retrieval last month, and we were able to get 14 4AA embryos. That's impressive, yeah. And a couple and some lower graded embryos. Should we do another retrieval if we're looking to have 5 children? Well, so the grade of the embryo does not correlate with its outcome. So I will tell you that, yeah, those are beautiful embryos. Those are great graded embryos. Really, Nadia, it depends on how old you are and what your age is as to how likely any given embryo can make you pregnant. So these are graded embryos, so they're blastocysts. Generally speaking, a blast is going to get you roughly about a 30% probability of pregnancy, an untested blastocyst. And we tell folks it may take 3 to 4 embryos, blastocysts, untested, in order to be able to achieve a pregnancy. So if you add that up, you got a bunch of great looking embryos there, but I'm not sure that it's enough necessarily to reliably say it's going to give me 5 children. So maybe you want to think about doing another round. So it all kind of depends on how you feel about that. Hello to Grayson Brocktongue. Nice to see you today. And my friend Christina Botto in Miami. Thanks for being here. Joni Rose says, what do you do differently in an IVF cycle in women with estrogen dominance? So nothing, because we're following all the hormone levels. Estrogen dominance, and there's some controversy as to what that really means in medical terms. But what it it has to do kind of with hormone balancing and how you feel. But as far as fertility goes, and as far as IVF goes, we're monitoring all the hormone levels, and we can really adjust and address those very specifically. So estrogen dominance doesn't play such a role in IVF. Be Kind, Be Love 116. That is a great name. You get a special hello there. Danny Dancer, Carmen is here. Florida Babe, Pretty V, nice to see you. Hi, Alyssa. Lily Rose says, is the priming done before IVF? I'm aiming to start IVF when I start my cycle sometime around March. I don't know if you mean March of 2025 or is that March 25th? Not sure which one you mean there, but yes, priming is stuff that we do before you start your IVF cycle so that we can try to improve. Really what it's doing is to try to improve egg quality. So priming means we're doing these treatments before you start the IVF. Hi to Vic from Orlando. Good to see you down in Central Florida. Oh, Okendo is from here, Orlando as well. Sokan Taiwo from Tulsa. Good afternoon. It's so nice to see people all over the map coming to join us here on a Tuesday afternoon. Gosh, it's 37 minutes after the hour. We'll be here until the top of the hour, trying to get to as many of your questions as we can, like we do every Tuesday. Let's see what we got here. It looks like Ann Rollins says, I had a diagnostic hysteroscopy and laparoscopy with a light DNC. Surgical pathology showed placental tissue. Could this really be from my pregnancy in 2022? Could it be a reason for 2 failed transfers recently? The answer is yes. Believe it or not, it absolutely can. So retained placental tissue changes the way the uterine lining talks to a pregnancy, and a pregnancy is allowed to implant. Now, I suppose it depends on exactly what that pathology showed, because there is something that will show up in placenta or in endometrial pathology that's called a placental nodule. And really what that is it's just kind of a little tiny spot. It's a scar where the placenta was, or what some people will call an eschar, where the placenta was. And it may be visible as something grossly on hysteroscopy. It may just be, I've seen it, surprise me and come back in a pathology result. But if it was actually placental membranes, placental tissue, and that definitely can have an effect on your ability to implant. Let's see what we got here. Do I need to schedule an appointment with a doctor to get an approval to transfer 2 embryos? No, you do not. Let's see. Lisa Palmer says, what are your thoughts on transferring after birth, after a C-section? Well, so, in general, we would want you to wait 9 to 12 months, really, at least before doing an embryo transfer. Um, More on the closer to the 12-month side if you've had a C-section, because we really want that we want that the uterus to heal. Now, I will tell you that the evidence, and again, I keep talking about the evidence, what the evidence shows when they study this sort of thing. They want to know, well, what's the optimum window? And the optimum window for getting pregnant again, they say, is between 18 months and like less than 5 years. So 18 months is kind of a long time to wait to get pregnant, and it's not clear to me if they say that you should be 18 months. Your baby needs to be 18 months before you get pregnant. So we will transfer embryos 9 to 12 months after birth. We, again, would prefer you not to be breastfeeding. Ashley Albee says, when does HCG usually start showing up on a pregnancy test after a day 3 embryo transfer? So we're usually doing that beta HCG at about 2 weeks after a day 3 transfer. After a day 3 transfer, you would be let's see, 2 weeks and 2 weeks and 3 days pregnant at the time that that embryo goes in. So usually it's by the time you would miss a period, which is going to be close to about that 4-week mark. So, it's going to be a few days before, 2 weeks afterwards, but that's generally kind of where we start to look for your pregnancy test. Hi to Shay, who asks, so I took a Gestin to start my cycle. As soon as it starts, I can start my IVF. Should I wait for my next cycle, or could I start this cycle? I hope this makes sense. It's so overwhelming trying to make the right decision. So Shay, it kind of depends on when. So basically what you're telling me is that you don't get normal periods. And so we can give you some progesterone. That's what agestin is. That will give you a period, quote unquote, a period. It'll cause you to have a bleed that feels like a period. And you can start your IVF at that point. Really, the question is, do you have your meds? Do you have your monitoring set up? Have you talked with the global team or the nursing team where you're going to be doing your IVF? And are you prepared in that regard? Because if that's the case, I would say go ahead, take your progesterone and start, sooner is better than later. Get it done with. Now, I will say that there are a lot of folks, particularly those with polycystic ovarian syndrome, who don't have regular periods. And if you don't have a regular period, normally we say, well, we're going to start your IVF when you get your period. And they'll say, well, I don't remember the last time I had a period. I think it's once a year. You don't have to have the period to start the IVF. So, and Shay, I don't know specifically what your scenario is there, but for many women, let's say with polycystic ovarian syndrome, who chronically don't ovulate, you chronically don't release an egg. The fact is, your body is sitting there and it thinks it's in the first part of the cycle. So it hasn't developed an egg. If we checked your lab tests, we would find you were at a baseline anyway. Like your body thinks you're at the beginning of the cycle. So you may not have to have a period. I think that's worthy of a conversation with your team to see if that's really truly necessary. Hi to Rebecca, who asked, does a high percentage of egg immaturity at retrieval suggest quality problems in the presence of diminished ovarian reserve? So yes and no, it can. So egg quality refers to really how stable that DNA is in your eggs at the time that we retrieve them. So if you have a bunch of immature eggs, the first thing that I would want to look at is, well, when were you triggered? Did you trigger maybe a little earlier than might be optimum for you? Or did we learn from your cycle that your eggs don't mature until a little later than the time that we normally trigger. So I would certainly, in the face of diminished ovarian reserve, want you to be doing all the things that we would do for diminished ovarian reserve, because that's going to have an effect on egg quality for sure. But the number of immature eggs may have to do as much with the time that you were triggered as well as what those eggs are doing when they're hanging out in your ovaries. Let's see. What else we got? We got a few other questions here. I'll tell you what. Let's shift back over here to the CNY side. So many people being here today. Alicia, Vegan Queen. Thank you, Dr. Fink. The first transfer made by you was a success. I'm holding my 7-month baby girl now. That is the best news I've heard all day. Thank you so much for sharing that with me. Gosh, I appreciate that. 7-month-old baby. Please send me a picture, would you? Noah L. Stewart says, how bad is the sperm extraction procedure? I hear mixed reviews saying that it's painful. Well, put it this way. Would you want to do it? Would you choose to do it? Would you like to do it? Probably not so much. How would you feel about someone putting a needle into your testicle? Probably not high on your list of things to do. They do numbing medicine. In some situations, they can do it with sedation as well. But I too have heard mixed things, and it sort of depends on whether it's a tessie, if it's coming from within the testicle or from the epididymis, where it's coming from. Sometimes it's really a very straightforward procedure, but it's quite variable, much like I would say an egg retrieval for women. There are some who say, oh my God, that was the worst thing I have ever experienced. And then there are other people who say, no, you know what? I was sore for a couple hours and sleepy and a little bloated, but by that night I was fine. It's a good question, Noah. And I think that the question to ask is, can you do it under sedation if you'd like? Will they offer that to you? Or is the numbing medicine enough? And it's not so much what happens during the procedure, it's afterwards. There's some bruising, there's some discomfort, sort of like, after a vasectomy, the guy needs to kind of stay still for a few days. They talk about putting a pack of frozen peas into your groin so that, you kind of basically be able to keep an ice pack on and decrease the swelling. Can embryos split during transfer? Absolutely, positively, yes. So the time at which an embryo splits to create what we would call to create a twin is an identical twin. It happens after the embryo is back inside the uterus. So that splitting process is not happening in the laboratory. It happens inside the body, inside the uterus. And so that's one of the reasons that we suggest you don't transfer things like 2 euploid embryos, because 2 can absolutely become 4. And that's starting to get to be a catastrophe. We don't want to go there at all. Cindy says, birth control started for IVF with another clinic and stopped 1 month later. Period is off. Will this be an issue for IVF with CNY? No. And we typically don't use birth control in most cases for people doing IVF. Many clinics will put folks on birth control because they batch their cycles. And what that means is they may have an embryologist that's only there a week out of the month, or they only have anesthesia a week out of the month, or there's staffing issues. They have OR nurses only a week out of the month. And so they'll put people on birth control so that they can try to batch all of their egg retrievals into one period, either a week or, within a week or 10 days. At CNY, we don't do that because we're doing 20,000 cycles a year. And so we have folks doing egg retrievals every single day. So we do have a list, excuse me, called our STEM Start schedule. And so we want to make sure that, we are being safe for each location. So depending on which location you're going to do your retrieval at, we don't want to overload our embryology lab and our staff. So there's a fixed number of STEM starts we have for each pardon me, for any given day. And so that's why we tell you when it's time to start. But no, birth control is not necessary and should not affect you to start at CNY. Excuse me while I have a sip. All right, much better now. Let's see. Rashmi is here. Hey, good to see you as well, my friend. Is it okay to start IVF with a hemoglobin of 10.4 and how to improve? So a hemoglobin of 10.4 is anemic. Anemia can have a lot of effects on you. It can affect your ability to produce eggs. It can affect how you feel when you produce those eggs. And it can have an effect on implantation. Anemia or a low blood count is usually a cause of, well, there can be several different causes, and that's something that we can generally easily evaluate with blood tests. In reproductive age women, the most common reason that someone is anemic is because of heavy menstrual bleeding from blood loss. So taking some iron will help to build that hemoglobin back, since iron is the main component of hemoglobin. And so if you build it back, and that may just normalize your blood count. There's also issues with some people have some disorders in the blood that make them appear anemic. Sickle cell, for instance, causes a type of anemia, or something known as a thalassemia. A B12 deficiency causes what's known as pernicious anemia. So these are things that I think are worth looking into, to doing the follow-up test with your primary to see what's the cause of your anemia. If it's simple iron deficient anemia, start taking some iron. The iron is generally 325 milligrams at 10.4. I'd say once a day will probably bring your blood count back up to normal within a month or so, and then you're okay. The only problem with iron supplementation is that it can cause constipation. So you got to be aware of that. Probably a stool softener is a good idea as well. Just makes sense because everyone loves to poop, right? Yes, indeed. Hello to Amber Vince in Kentucky and her ongoing pregnancy. So happy. Hey, Kate Mitz is here. 5 weeks and 4 days pregnant with twins. History of losses. Congratulations, Kate. That's fantastic. Is there an increased risk of miscarriage with twins? Well, a twin pregnancy, creates an environment inside the uterus where those babies are competing with each other. So I am fond of saying, as my brother will attest as well, who is several years older than I am, that sibling rivalry actually begins at the moment of conception. Sibling rivalry takes place inside the uterus. So a twin pregnancy is associated, with higher risks, but not necessarily, Kate, a higher risk associated with a first trimester loss. So it just depends on, there's an increased risk for preterm labor and issues with the cervix and so forth. It depends on the type of twins. But in the meanwhile, our fingers are crossed for you. Congratulations on the twins, and God bless. What good news that is. Pardon me again. What should this is from Lady Gemello. What should my endometrial lining be and my estrogen and progesterone levels be at transfer? So we're really looking to have, pardon me, your endometrial lining to be about 7 millimeters before you start your progesterone in an embryo transfer cycle. That's kind of the most important feature. Progesterone, estrogen level, we don't care too much about. In fact, there's really no reason we really need to test it. The progesterone level is going to be more important kind of when we do your midway labs. If you're doing a modified, or if you're doing a natural cycle of some type, we want that progesterone level to be at a 10. If it's a medicated cycle, we want it to be at a 20. Hey to Devin in the beautiful Florida Keys. Thanks for being here this Tuesday afternoon. Well, we've got about 5 more minutes, so let me see what I can get in here. Looks like, let's see, Shay is asking from Facebook, is it necessary to have a fibroid removed if it isn't affecting the uterine cavity? I would say no. If it's not affecting the uterine cavity, we generally will leave it alone. Shay says, I discovered a fibroid after 4 failed IUIs, and I'm looking at switching to IVF after getting it checked. Well, so the fact that 4 IUIs didn't work for you doesn't mean necessarily that something's wrong, because the overall success rate with an IUI is not that high anyway. It's higher than it would be for home intercourse, which would give you roughly about a 1% chance per cycle. An IUI is going to give you about a 9% or so chance per cycle, whereas IVF can give you up to a 65% probability of pregnancy per embryo. So IVF is going to have a dramatically higher chance of pregnancy for you. You know that the IUIs didn't work, just like every cycle, if you have intercourse at home, it doesn't necessarily work. The success rate is not so high with IVF that I would say there's something wrong with you because your 4 IUIs didn't work. In fact, what we do know is that 5 IUIs, if they're not successful, means that you're no more likely to get pregnant with your IUI than you would be with home intercourse. So at that point, for sure, it's time to step it up and do something different. Camellia, I believe. It's a little far away. I can't see it. If a woman has a shorter cycle, would starting meds earlier keep them from having a lead follicle? I just started IVF this last cycle. I didn't have my baseline till cycle day 4 and didn't start my meds till day 5. My next ultrasound already had a lead follicle at 15. The others didn't grow. We canceled this cycle, but can things be different for another cycle? In that situation, I would suggest, if you can, starting day 5 is pretty standard kind of time to start. It may just be the way your ovaries produce their eggs, and certainly that sort of thing is more common in women with lower ovarian reserve. But I might sort of think about starting my stim a little bit earlier in that scenario. Yes, indeed. Let's see here. David is asking, Harmon from California. Well, actually, it says I'm Harmon from California, not David. My regular periods did not start until 14 days after my egg retrieval. Okay, yep, that's all right. So typically 10 to 14 days after your retrieval. So it's usually about 14 days after your ovulation. So we triggered your ovulation with the trigger shot. Well, you didn't actually release the egg. We took the eggs out, but 10 to 14 days after your retrieval is the time that we would expect you to have your period. Yeah, so that much is okay there. Oh, let's see if we got something else here. Florida Babe asked, do I need to be on my cycle to do all the testing? No, you don't. So the testing that we do, the blood testing we do, is cycle independent, which means that you can do it at any time during your menstrual cycle. If someone tells you, nope, you have to be, well, we used to say that the FSH blood test we wanted to do on your cycle day 3. But that is no longer a thing because the AMH test is more important for us to be able to know how you're going to respond to medication. Cycle independent for your blood tests. But if you're going to be doing a saline sonogram or an HSG, the dye test, those typically need to be done between days 5 and 11 of your cycle. But the blood, nope, you can do that really at any time. When do you recommend an HCG wash for a fresh transfer? Ideally, we do it the day before your embryo transfer. Sometimes we can do it the day of as well. However, beforehand is generally a much better idea. Is it common to use immune protocols for natural recurrent pregnancy loss patients? So that's one of the indications I would say for sure that I would want to use something in the immune protocol, because there may be immunologic reasons that your pregnancies weren't continuing. Yeah. What about estrogen during a modified natural cycle? So, during a modified natural cycle, your body is making its own estrogen. You form a follicle in the ovary, and that follicle grows, and that's where your estrogen is normally made. And that's the way it does it every other month, even those when you're not trying to get pregnant. That estrogen builds up your lining in the uterus. When that ovary releases its egg, that's when you start to make your progesterone. So you're making your own estrogen and progesterone. I emphatically do not recommend that you treat an estrogen level in a natural or a modified natural cycle. If your lining is not thick enough, then yeah, we'll give you some extra estrogen, because even though it's a natural cycle, that just means that the hormones are coming from you as opposed to coming from, an outside source, something artificial. The only job of the estrogen is to build up the uterine lining. And if the lining is okay, you don't need extra estrogen. Do not treat a blood test level with that. However, if the lining's not thick enough, yep, we'll give you some estrogen. If your progesterone's not high enough, yep, we're going to give you some progesterone. Gosh, it's top of the hour. Boy, this has gone by so fast today. So great to have everybody with it. This is Super Tuesday, by the way. If you are in one of the voting states, please exercise your right and go out there and vote. Make your voice heard, because that's the only way we can make positive change in our political system, which frankly is pretty messed up right now. We'll be back next Tuesday, and I hope you all will as well, like we are every Tuesday evening. So, live here from Colorado Springs, my name is Dr. Randy Fink, and it's such a pleasure to be with you. Please remember what I say. This business about infertility is not the book of your life. It is only a chapter. And what we are doing is to help you rewrite it. So God bless. Thanks for being here, and good night.